Welcome to our next panel, Wellbeing is More Than Healthcare. My name is Nina Simon. I'm the Executive Director of the Santa Cruz Museum of Art and History, or the MA. And I want to welcome up, yay for the MA. I want to welcome up our panel today, Dr. Josh Bamberger from UCSF, Michael Woolward, who's here from Hospice of Santa Cruz County, and Holly Hughes, who is the Director of Behavioral Health at Santa Cruz Community Health Centers. And give it up for these fabulous guys. As did the last panel, we are going to have lightning talks from our group, followed by a group discussion with all of you about this topic of well-being being more than healthcare. And just to kick it off, I looked up well-being online, and when you look up well-being, you do not see photographs of doctors or things that we normally associate with healthcare. You see images like this. Or maybe if you want a more regional image, images like this. Images that are images of each of us having experiences where we are, as Kate mentioned this earlier, healthy, happy, and together is another one I would put in. That arrow, that was me. This is from an event last year when the Museum of Art and History hosted a celebration of the Hawaiians, princes who brought surfing to Santa Cruz 130 years ago. And I bring this image up because I want to just invite you to think about three big ideas about well-being as we talk about well-being throughout today and really about it related to healthcare. And the first is this. Well-being is not just about you and your surfing or yoga practice. It is for everyone. And whether you are dancing in the streets or whether you are making theater, this is El Teatro Campesino in San Juan Bautista, or whether you're enjoying art at our museum in Santa Cruz, this kind of well-being is not a luxury good. It's not that you get all of your healthcare needs at your bare minimum and then you get this kind of well-being. Well-being that brings us together in shared celebration is for everyone in our community and in our region. The second idea I want to invite you to think about is the fact that well-being is interpersonal. We often think about our well-being in terms of our own health. How am I doing? How am I feeling? But the reality is that every one of us, our well-being is contingent on our ability to connect with other people who support us and who invite us into greater health and happiness together. Every one of the people in this picture is having their own experience of well-being, but they're also doing it together. And there's a lot of research that shows that when we bond with people who are like us, it creates a certain kind of well-being. It provides certain health outcomes. The people we bond with are the people we call when we need soup and we're sick. But the work we do at our museum is actually more focused on how we can invite people to bridge with those who are not like us. Because there also are health outcomes that come from our connections we make with people across race, across ethnicity, across generations, across income. We may not call these strangers when we're sick, but feeling comfortable and excited and happy to be around them invites us to feel safe and welcome in our communities. And so finally, I just want to invite you to think about the idea of well-being not as an individual pursuit, but as a collective effort. This is a picture from the Glow Festival we hold annually in Santa Cruz in Abbott Square right outside the museum. It's a particularly Santa Cruz image of well-being, I think. But this boy who is operating this flame device, his well-being is supported by the collective effort of everybody else in this picture. Everybody who bought a ticket, who showed up, who volunteered, who made a donation to support the kind of joyful sharing that's happening in an arts experience, in an outdoor experience, in a community experience. So as you think today and as you hear from these great speakers about how we think about well-being being more than healthcare, I invite you to think about how we can all act to support well-being for our region, not by focusing on our own experience, but by focusing on the collective effort, the opportunity to show up, to make a donation, to be a volunteer, to get engaged in inviting everybody in our community to share the joy and the happiness that really makes well-being and health whole. So with that, I'm going to invite up our first speaker, Dr. Josh Bamberger from UCSF. Please join me in welcoming him.
Thanks.
You can use this clicker, or you can use
I'll use this. Hi. Good morning. So I'm Josh Bamberger. I'm a family physician, and I've been taking care of homeless adults in San Francisco for the last 28 years. And over that time, housed many, many people. And I'll tell you this, there's no secret that there's nothing I have in my black bag, no arrow I have in my quiver that changes the likelihood that a homeless person is going to survive longer or better than housing. There is no medication, there is no vaccine, there is no exercise, there's no meditation, there's no walking up to the top of a mountain that in any study has ever been shown in any country will change the likelihood that a homeless person will live longer than housing. And yet it's the least resourced treatment that we have in the healthcare sector. That disconnect has driven me for many years to figure out ways to improve the health of the people I serve. And it has also almost broken my heart many, many times. As I continue to care for this one veteran in my clinic, who I roll out to the street corner every afternoon I leave my clinic. And I get in BART and go home. And he's still there under the rain and the wind to suffer on the streets because we have not figured out a way to serve this one particular individual. That is wrong. That is not what a just society does. We're at a difficult time in our country. It's hard to know where justice is going to, where the arc of justice is going to go. It's hard to find a way to get up in the morning and find a way to advocate for the people who don't have a voice. But here is our opportunity in this room, gathered together in this beautiful part of the world, to find a way to bring housing to people who can't often advocate for themselves. I'm going to give you some very brief data on how you can do this, and then I think what I hope is that when you leave here today and you go back home and you see your kids and you see your partners and you say, we have to do better for the people who don't have a voice. And we can do this now, and we can do this in a way without having to actually spend any more dollars than we have today. So I'll try to give you that formula very quickly, and we'll see if we can leave today with some hope in a time when hope is a little bit hard to find. First of all, housing is good. Duh, right? But saying the obvious is sometimes really important because we don't recognize that you have to put it out there, that housing is a good thing. And we're the only creatures on earth that don't fight for housing as the first and last thing we do in the morning and at night, right? Every other animal does that. So why is housing good? Well, here's a graph of data that maybe will help to make a case that housing is good. This is an interesting study that I did in San Francisco where I looked across 13 buildings that I control access to. So I run the housing system for the health department in San Francisco. I have about 43 supportive housing buildings. These are 13 that I ranked from the least beautiful by the Josh Bamberger scale of beauty to the most beautiful. And just some examples, this is the least beautiful building called the Windsor, which is a renovated single-room occupancy hotel in the Tenderloin. This is the medium beauty, which is pretty nice looking, called the Plaza, which is on the corner of 6th and Howard, and this is the most beautiful called Mission Creek, which is a building for seniors right next to AT&T Park. Now, if you graph these things, I'm going to go back a second, and you look at the mortality of people who happen to be placed in these buildings, and I'll tell you, I take the sickest people and put them in the most beautiful building. So if you look at the mortality, you see the people who are in the least beautiful building have a much higher mortality than the people who are in the most beautiful building. And this is contrary to what you would expect if all other things were being equal. And that's what this line shows, is that the beauty of the building changes the mortality of chronically homeless single adults when they go into housing. How does that happen? What is the biology of that? Where does that come from? And how can we get back to Nina's beautiful introduction about the importance of beauty and self-determination and having a reason to live? These data show this in a way that's very powerful and kind of hard to understand. You will not find a cortisol level that will correlate with this, but beauty matters. In this study, we looked at all people in San Francisco who were homeless at the time of their AIDS diagnosis between 1996 and 2003. So this is during a time when everyone in San Francisco had access to triple cocktail antiretroviral therapy, and today is World AIDS Day, so it's important to sort of pause for a moment and think about when I started at resident at San Francisco General in 1989, there was no treatment for people with HIV/AIDS. And yet during this era, we found that people who were homeless at the time of their AIDS diagnosis, who were not housed in my brand of permanent supportive housing called Direct Access to Housing, had a 75% mortality rate after 5 years. So only 25% of the people who were homeless at the time of their AIDS diagnosis lived past 5 years, despite having excellent access to medication. And yet the people who were housed in my building, represented by that red line, only 2 of the 49 in this study died. With this, a mortality improvement that will kick the ass of any medication you'll ever develop. And yet we don't invest in this as a healthcare treatment to the extent that we could actually do to bend the mortality curve. And yet the people who were represented by the blue line died at the rate as they did when I started taking care of people with HIV in 1989. Medications were insufficient to change the mortality curve without the cofactor of housing. You can have a 4th medicine, a 5th medicine, you can treat, you can do anything, but it doesn't matter. You're living in an Alice in Wonderland world if you continue to prescribe or advocate for medication without housing for people who are on the streets. It's a waste of your taxpayer dollars. Stop doing it without housing. This is a study that we're in the midst of right now, which is a randomized controlled trial of permanent supportive housing, the highest level of research that we can do. We took a bunch of people in San Francisco and we randomized them into housing or regular care, which is probably unethical, right? We know housing is good, and to sort of not house people because of research goals is a bad thing. But we wanted to do this anyway so we could prove to everybody that housing is a good thing to do, not just for mortality, but in this case for cost. And what you see by these 2 graphs is you see the people who are in the treatment arm, people who are housed, started out at a very expensive cost, just in healthcare costs, about $30,000 a year. And after they were housed, in 1 year, they dropped down to about $12,000. And that delta, the difference between the cost before and the cost after, is more than the cost of the housing. So you can house people, change their mortality, improve their quality of life, give them beauty at less cost to the government than leaving them on the streets. Why don't we do this? And then more importantly, in the people who were not housed, they were more expensive after being placed in housing. Without being placed in housing. The people who are on the streets continue to be more expensive. So the randomized trial is a really important strategy that we can prove that if you don't house people, they get more expensive. So again, just irrational. It's a rational world, perhaps. We want to bring some rationality to it. How do you do this? So here's a supportive housing puzzle. As you've been mentioned, the previous speakers in the previous panel talked about how you do housing. Well, there are really 5 pieces to this supportive housing puzzle. Some of them are easier to get in different communities, some of them are harder. Development costs, land. There's a lot of land out here. Not all of it has plumbing. Can you use it, et cetera. Rental subsidies are really typically the bottleneck in supportive housing development. Where can rental subsidies come from? Housing and urban development is funded at 1/8 the amount that they were in 1972. And yet, the cost of housing has increased and the number of people living in poverty has gone up. So we're not keeping up with what we were doing in the Nixon administration. How do you make it work here in Monterey and the surrounding counties? Well, there are some amazing leaders here in this room. It's not as bad as herding cats. There are funding streams that are out there that you can pull together and create a flexible housing subsidy pool. That's what this slide shows. And into that pool can feed Medicaid. The whole person care is something that Monterey County has. Assisted living waiver, a 1915C Medicaid waiver, which none of the counties around here have, but could easily get in the next round, that gives $56 per day for people who are on the trajectory towards nursing homes, for nursing care and homemaker care. Philanthropy, community benefit obligations. So every nonprofit hospital must give 10% of their revenue back into the community. And housing is something that the IRS has proven is an acceptable community benefit. So go to your nonprofit hospitals and say, why are you giving money to charity care when everyone's insured now? So the amount of people who are insured has gone up, and the amount of obligation that they can give back to take care of charity care has gone down. So there's a pool of money that's there. And other places like the Central California Alliance for Health has a big profit, which they've given back into the community at about $2.5 million they're giving this year for supportive housing, out of a total of $112 million that they're giving in philanthropy. Why not 50 million? Why not 110 million? Why not more than their profits? You know, great people making great decisions, you have to push them to do that. So that's the things that can go into the pool, and then coming out, the supportive housing puzzle. Services, rental subsidies, development costs. So here in Monterey, Santa Cruz, San Benito, you got to bring it together. Bring in philanthropy, bring in the hospital community benefits, use the whole person care for services. Health homes is another Medicaid option that's out there that's bringing in significant revenue. Who's going to be your leader? Who's going to say that the healthcare system must point towards housing and somehow get the arc of justice to bend towards the people who don't have a voice? You can do this. The pieces of the puzzle are out there, and I really look forward to being a part of the discussion that will make the folks who are living with just tremendous suffering less. Thank you.
Thank you, Josh, for bringing in a bigger perspective on a crucial part of this issue. Here to talk more about the whole person part of what Josh was just alluding to is Holly Hughes from the Santa Cruz Community Health Center. So please join me in welcoming her. You can use this button, or you can use the space bar, and that lady will show you a sign on them.
Okay, thank you. I'm working with my colleagues in a primary care medical setting to change the way we deliver health care. Here's a window into the medical appointments of the patients I care very much for. A 56-year-old woman in for neck pain. She has been homeless and sleeping in a van with her husband, who is recently out of prison. She admits that he was abusive in the past, but denies that the bruises on her arm are from him. An 18-year-old mom in with her baby for a well care appointment. She is suing the father of the baby for full custody because he was abusive during her pregnancy. Next, a 9-year-old in for asthma exacerbation. He and his mother, who works full-time, have been homeless for months, compromising his treatments. Finally, a 66-year-old woman in for diabetes, hypertension, and obesity. She can't eat fruits and veggies because she has no teeth, has difficulty getting around to food pantries, and has no access to a real kitchen. How can a physician alone possibly impact these circumstances? What is the healthcare system supposed to do? The medical slice on this chart hits only 10% of the indicators of someone's health and well-being. So let's integrate whole person care by combining medical, mental health, substance use, and social determinants treatment all in one location. And let's be sure that the patients are seeing the right provider for the right reason in real time. What does that look like in practice? Sometimes we foster social connections and support by reaching out to estranged family members or friends because there is a correlation between loneliness and poor health outcomes. Sometimes we call a landlord to advocate for a patient to remain in housing despite the police being called the night before due to a domestic dispute. Sometimes we accompany a patient to a medical appointment so anxiety levels are lowered and communication is clearer. But we do know that sustained health changes occur when people make those changes for themselves from an intrinsically motivated space. So when I meet with a patient, it's like I walk over to a deep well, lean over, shine a big light inside so the person can finally see the ladder. I don't build the ladder, I simply illuminate it, offer care and encouragement, and witness the exit. Some people don't get on that first rung right away, and I accept that. But I come back the next time they're in the clinic to shine that light again. I respect their autonomy, I respect their pace, and I graciously return again and again with that big light, a caring presence, and heartfelt encouragement. When we offer that kind of approach combined with partnering with our patients to address social challenges, trust and hope build up over time. Sometimes it means navigating care across systems so people don't fall through the cracks. I sat with a patient who was in danger in her relationship with her partner. We called the crisis line together. We arranged for the van to meet her in a neutral place. We mapped out a plan for her kids to be taken care of while she was away. She entered the shelter and participated in their program to gain and sustain safety and independence. During that time, she came to the clinic for medical and mental health support. And that was 2 years ago. Today, she's separated from her partner, enrolled in a fine arts program, working as a successful tattoo artist, and enjoying being a present, joyful mom. She says we saved her life that day. How can you help? These are uncertain times, especially for people experiencing homelessness, for immigrants, for marginalized groups, for people who were living without health insurance for so long and may now be at risk of losing it again. Medicaid expansion has saved lives. I see it every day. In community health settings, we have been kicked in gear to create a better system of care, one that treats the whole person. We have this foundation and we need to keep building. It was a heavy lift before the election, and now it is imperative that we unite to keep this momentum alive. Your voice is needed when it comes to equitable access to health care. Join the boards of community health centers to help strengthen their fundraising capacity. Write a letter to your state and federal representative in support of the Affordable Care Act's Medicaid expansion. Educate yourself about health policy. It's complicated. Read information from Vox.com, The Incidental Economist, Health Affairs, and our other academic sources. Homeless people are people who don't have housing. They aren't criminals. So let's participate in larger societal solutions to reduce and prevent homelessness. Donate to Santa Cruz Community Health Centers or a community health center in your neighborhood. Social work is a growing field. We desperately need bilingual, bicultural young people to pursue this career path so the need is met with a qualified workforce. Finally, this is Sophia and Davi. Santa Cruz Community Health Center's care team supported them both during a stressful time in their lives when housing was threatened and healthcare access was complicated. As a result of whole person care, she and her baby are in a better place. As we continue this important conversation, I hope you'll keep the patients you've heard about today in the forefront of your minds and hearts. They represent the 30% of Santa Cruz County residents and the 40% of Monterey County residents currently covered by Medi-Cal, which is nearly 250,000 individuals.
Thank you, Holly. Thank you, Holly, for sharing those stories and the work that you're doing. Our final speaker is Mike Millward from Hospice of Santa Cruz County, bringing beauty back into the conversation in a way that's really going to make you think. Please welcome Mike. So you can use the arrow or the space bar key.
Well, thank you, Nina, and good morning, everyone. You know, I thought as we continue to explore this idea together, the idea that what it means to be well is more expansive than healthcare, and certainly includes more than physical health, that I would ask you, is it a good day to die? Well, of course we hope not. And still the question does beg other questions that I think add a different texture and quality to our conversation this morning. We might ask, what does it mean when we speak of living a good life? A life of purpose and meaning, a life rich in the quality of our relationships. Perhaps a life that reaches out to lift up those with less, so that everyone is welcome and no one is left standing, as Greg Boyle might say, outside the circle of kinship. Or this morning we might say outside the circle of equity. Now at this point you might be wondering, what is the hospice guy doing on this panel? What does being with the dying teach us about well-being throughout our lives, including at the end of life? In my time as a hospice chaplain, it has been my privilege to be with hundreds of patients and their families as they lived into the last months, weeks, and days of their lives. This is a time when palliative medicine and hospice care can be especially present, address symptoms and alleviate pain, and it is also a time when healthcare can certainly no longer cure. This is a time when what it means to be well has everything to do with a life well lived. Our well-being is found in what our lives have meant. As they say, have we made a difference? Have we given and received love? Physician and author Atul Gawande, who has studied the subject of healthcare and what matters most at the end of life, he says it this way in his New York Times bestseller, Being Mortal, after all, it is not a good death we seek, but a good life all the way to the end. You know, there's a wonderful story about John Quincy Adams, who on his 80th birthday, he was asked, in essence, "How are you?" Responding with the wisdom of one who knows that our well-being is much larger and more stable than the physical body in which it resides. He is purported to have said that John Quincy Adams is well, but the house in which he is living at present is quite dilapidated. It is tottering upon its foundation. Time and the seasons have nearly destroyed it. Its walls are much shattered, and it trembles with every wind. I think that John Quincy Adams will have to move out soon. But he himself is quite well. In hospice, we are very fortunate to be invited into what is precious time, to be sure that we see that meaning is often found in faith, literature, music, and art. Almost always, well-being has everything to do with relationships. As we are able, our well-being is discovered in conversations of both gratitude and reconciliation, where stories of our shared lives abound. Anti-war activist and Jesuit priest, the late Daniel Berrigan, says it this way: first things recognizably first. Now this morning, I don't want to romanticize this reality. It is certainly not something we choose. God willing, today is not our day. We are busy, our lives are full, we have work to do. And one thing we can do today for ourselves and for those we love is to make sure that they know how we feel, that they know what it is that we would choose, what about our preferences for care, so that they are able to advocate for what it means for us to be well then, in the event that we are no longer able to make decisions for ourselves. This is a gift for us, to be sure. It is certainly a gift for those that we love. I will leave you this morning with this. Mother Teresa once described the world's ills in this way: we have just forgotten that we belong to each other. Well-being finds this truth to be self-evident. Well-being includes this body, and it certainly includes health care, and as we have said, it is much more. What I have learned at the bedside of the dying is that what matters most at the end of life matters most throughout our lives. Turns out, as we write the last chapter of our life story, as we survey the landscape of what our life has meant, what matters most is that we do, and we always have, belong to each other. Thank you very much.
Jennifer Coyle, several affiliations here today, but I just want to acknowledge that today is World AIDS Day, and it's my understanding that the nonprofit providing AIDS services in Monterey County closed last year. I'm not sure of the current status, but can we commit to making sure that in the health and housing services for people HIV positive or with AIDS, that we will plug any current gaps in services?
Josh, do you want to speak to that?
I agree with her. Today is World AIDS Day, as I mentioned before, and certainly my feeling as a family doc is that HIV care should be integrated into all other care. And the reason why people die from HIV these days has much more to do with poverty than it does to do with the virus. So many of the reasons why we live, and this beautiful presentation about how we die, I think integrates beautifully with our opportunity to advocate for people who don't, again, have the opportunity to get indoors. That's what kills people with AIDS these days. Clive Jones was on NPR. I don't know if you heard him. He's someone I've been working with for many years. He's the founder of the AIDS Quilt. And the guy was HIV infected in 1978. Still alive. He has a home. Many of my patients are dead.
Linda Manzolini with Eden Housing. Just a question for Joshua about the the Medicaid waiver, Medi-Cal waiver. And can you talk a little bit about that and how a region accesses that? Because I know San Mateo has done it. And how might this region do that? Because I think that's a really important source for the homeless challenge.
Sure, yeah, it's a really complicated, simple statement, complicated answer. Medicaid waivers are many, okay? So a waiver is something that the state requests of the federal government to allow Medicaid to be used in a way that is not within the Medicaid regulations. So for example, the state of New York requested to the feds to allow Medicaid to be used for rental subsidies through something called an 1115 waiver. That was denied by CMS in the Obama administration because housing is not something that is supposed to be used with healthcare dollars. So the state of New York then went on their own and used their portion of the Medicaid dollars to invest in housing through something called the Medicaid Redesign Team, which has brought $560 million of healthcare dollars into housing in New York State. Here, Monterey County has requested to be participant in not whole person care like you talk about, but very specific, narrow waiver, one of the 4 approved waivers that California has in this 5-year cycle called the whole person care waiver. And that allows communities to take Medicaid dollars and use it for high users of the healthcare system. And if there's shared savings, it can be used for rental subsidies and for development costs. So Monterey is doing that, Santa Cruz is not. San Benito is not. But Monterey is about to get awarded a chunk of change, and you can figure out how to do that. Why is it that Monterey did that and not Santa Cruz? It has a lot to do with the match that the county has to put in to allow it to qualify for that. So that's one waiver you have come down the road that you can use. Then there's a 1915 waiver, which is the home and community-based waiver, which also Monterey, San Benito, and Santa Cruz does not have, but 14 other counties in California does. And that allows Medicaid dollars to be used for home services to keep people in their home instead of nursing homes. And that is a very unexploited opportunity across the state because there's something called the publicly funded housing option of the Medicaid, of that waiver, that almost no one has used. So for all of you entrepreneurs out there who are trying to figure out how to make some serious change by using what's left of the Medicaid program in California, this is a real amount of money that no one except a home health agency in Los Angeles called Libertana has tapped into. It's a minimum of $56 per day, and with that money plus someone's SSI, you can build buildings and end homelessness. So in the next cycle of that waiver, I strongly encourage Santa Cruz, Monterey counties to get in and request to be a participant in the assisted living waiver.
Thank you.
That's a lot. Hope you followed that.
And Holly, you mentioned in your presentation that Santa Cruz County, 30% of people are on Medicaid, Medi-Cal, Monterey County, 40%. Kate talked about some of that in the dashboard. To this idea of belonging to each other, how can all of us in this room be more engaged with and more supportive in thinking about what those 30, 40% of people in our community, those 250,000 people in the region, need to really have successful well-being in this way?
Well, I think just the awareness, I think, helps to have eyes opened to the numbers of individuals, the diversity of that group of individuals. I think a lot of assumptions get made around who the us and them versus we. And I think that's a helpful concept to just begin to set an intention a little differently. And then I do still believe in the power of just conversations with friends and family and colleagues, just to continue to dialogue about this, so that change, can continue to happen.
Mm-hmm. People might remember at the last MBEP event that was in Santa Cruz, some people had a red dot on their name tag, and we were talking in that case about people who were below median income, but just being attentive to how many people in our community are impacted in different ways by these services and by these issues. Yes, we have a question in the back.
Somewhat of a personal question, and I would direct it to Josh, but it also would pertain to the other two. I'm Chris with the Pink Flamingo Theater, and the personal question really is, when you're armed with the knowledge that housing affects health care and it extends somebody's life, and that the housing is actually cheaper or less expensive for the government than having them out on the street, how do you keep your sanity with that knowledge and seeing that the government just doesn't jump on that to save money and save lives, but that you continually have to fight this fight? How do you personally handle that on a day-to-day basis? Thank you.
Lie down first. Is there a couch here that I can lie down? Hey, thanks. I have two sons who are 14 and 10, and I truly believe that I want to create a world where they read about homelessness in the history books. I've seen tremendous progress. Thanks. I've seen tremendous progress. The project that I'm most involved with right now is going around the country and documenting where healthcare dollars have been used to expand permanent supportive housing. And in Minnesota, they're on track to end homelessness in 3 months. So I think to answer your question directly, I grasp at hope, and then I see that the places that aren't achieving that have opportunity. Maybe it's Pollyannish, but I worked in the Obama administration in the first term, and I saw amazing people trying so hard to do good things for people. Very smart. And I don't think they're going away in Washington. They're still there inside the Beltway. There's still smart people there. And I think we'll get there if we keep questioning the absurdity of the world. I don't know, drink a lot of wine.
The MA is a museum of art and history, and we often talk about this idea that we use history to think about where we came from and art to imagine where we can go. And I think that while art will never be the answer the way housing is the answer, finding those opportunities to imagine those futures for your sons, for all of our kids, and for ourselves and our communities is a really important part of this. And I encourage you to visit in the marketplace some of the folks who are working on housing, who are here and are really working both on permanent supportive housing, but other initiatives to invite us to move forward around this crisis.
I just want to say one more thing to sort of tie these things together a little bit. Having worked with, I worked in the AIDS crisis from 91 to 96 with my friends at Laguna Honda Hospital, which is the large public health hospital. We had 900 people die in those 5 years. The life expectancy of someone who came into that facility was 28 days. And working with people who are dying is incredibly motivating to get up and do what you need to do for the people who are living. So to tie this stuff together, the acuity, the richness, the beauty of stories, it's just fantastic. And I feel very lucky to be able to observe the human condition.
We're going to take one more question from the group, and then, maybe we can do two. I think we can do two. Yeah, we've moved the break, so go ahead. It's okay, it's on.
Thank the panel for your very thoughtful and very deep impression for me in these presentations. Joshua, I had a question, especially for you, but also that pertains to the housing success. The successes in housing for the homeless. Many years ago, I had heard of and was following Housing First that came out of Sam Sembritz, I think was his name, out of New York City. It's idea that the best kind of help for the homeless would be to provide the housing first and then the services later. And I know that in many states there have been great successes. But following the 80-20% rule, what are the programs that we should be looking at and backing? And which are the ones that are making the success that you just alluded to?
Thanks for asking that. And so Housing First is a program, very self-explanatory. Right? Move people indoors first, and then their substance use, mental health issues will improve. And you leave them on the streets, they're not going to get better. So what are you waiting for? You got to take the investment first. Los Angeles County right now is really the leading edge in terms of making headway on homelessness. Mitch Katz, who's the health director in Los Angeles, has an $8 billion annual budget that he controls, $8 billion. He is making the largest investment in permanent supportive housing across the country. He's invested $20 million of health department money to expand housing that's going to get up to 10,000 new units of permanent supportive housing. That sounds like a lot, right? 10,000 units, can you imagine in this area what that would do, right? But that's 0.3% of his annual budget. So California Central Alliance for Health, you know, $2.6 million of philanthropy given to Santa Cruz and to Salinas to make new supportive housing. That's fantastic. That's the largest investment by a managed care organization in the country. It's less than 3% of their budget, their philanthropy budget, right? So it's hard for me, I don't want to like criticize the largest commitment that Alan McKay and his group have made, because it is fantastic, but we have to ask for more. We have to ask more of our healthcare system. We have to stop spending money on expensive medications and unnecessary tests and gauze pads that aren't necessary to be there for people who go into emergency rooms and get a $10,000 bill. We have to stand up and say that the healthcare system has to be responsible for the sickest people first and get them into housing first, and then the healthcare costs go down, the health improves. But we have to co-opt the healthcare system. So whoever is in here, from SOTR or whoever you are, we have to make this our goal for the next 4 years, to fight against the tide of having voiceless people not have a voice.
Well, and I want to invite for a moment, can I ask everybody who's working on housing first in our region to stand up, because I know there are many of you who have been real champions of that in this room. Don't be scared. Please stand up, Phil, Monica, Sibley, Claudia's back there somewhere. And don't just clap for these people. The reason I asked them to stand up, stay standing, stay standing, stay standing, is that I hope that when we take a break, Don, thank you, that you will talk to Josh because he's fabulous, but you'll also talk to these people who are here in this room who have been doing this work in our region in a really incredible way. Not at the scale of LA, certainly not with the budget of LA, but are having some real change. So I invite you to meet those people who are getting some of this work done in our community as well. I want to invite our panel, before we go, if you could share just one thought on something that you hope as we go into the break, as we go into the rest of the day, you know, what's the one thing you really want people to take with them or to come chat with you about or think about doing in their own life? And let's keep it short because I was already given the this before I said this. I'll invite Mike to start.
Well, you know, I was thinking as my panelists were speaking that what we have in common is we're working on taking care of the whole person at a time when they're vulnerable. And Josh alluded to it, but you know, 50–60% of the Medicare dollar is spent on the last 6 months of life on often unnecessary, painful, very expensive treatment. And I think what we're all doing, Holly's work with whole person care, is not only a huge uptick in terms of quality of life for folks, but what's not being said is that these folks are in the ED less. They're admitting less, they're readmitting less, they're saving lots of important resources at the same time that the quality of their life, even at the end of life, is greatly enhanced. And I think that three of us, I think, spoke to that in different ways.
Thank you. Josh?
I would just love to see in 2 years that you find a 100-unit out-of-favor hotel somewhere in this area where there's a lot of sex work and drug dealing going on now. Buy it, renovate it, and move 100 people off the streets and into that housing in the next 2 years because you guys get yourself together and get the financing. That's what I'd like to see.
Thank you. Holly?
I guess I would just say that to keep in mind that the changes that have been happening in primary care settings around integrating behavioral health with medical care, there already are some conversations happening around taking some steps back from the progress that we've made. And the knowledge and the evidence around behavioral health being a core service right along with medical care, I just would hope that we could keep that momentum going because there really are ways to work with systems to, if people are aligned with the values and the intention, then I do think that it's possible to keep that moving forward.
Thank you. And I would just say, enjoy your well-being. Enjoy our well-being in this beautiful community full of natural resources that are incredible, full of creative resources that are incredible, but do so mindful that we belong to each other and that the well-being that we want for ourselves should be and can be the well-being that we want for everybody in our region. Thank you for joining us. I think Mariah's going to come up.